And we lose our best employees who go down the street or around the corner to find a better insurance plan. So we do the training, we do the recruitment, and then we continue to be uncompetitive. And I don't think there's any group of employers in America who will benefit more from the structure of this health reform bill than will those small employers who really are the backbone of the economy. They're going to be the backbone of our recovery. It starts with tax credits this year, which graduate from 35% up to 50%. It continues on with a new market by 2014, a real ability to be pooled in much larger groups so that the size of the firm doesn't penalize the insurance prices. It makes sure that they have some competitive choices along the way, and that low-income workers will be eligible for subsidies. So a whole series of benefits aimed at the people who right now are priced out or squeezed out or locked out of the market, and I think making them much more competitive and much more able to attract and keep the kind of talent they need. This bill has an enormous emphasis on prevention and wellness. You know, we continue to do, I would suggest, some really crazy things in our healthcare spending in this country. 75 cents of every dollar is spent on chronic disease and treating chronic disease. 8 cents of every dollar is on prevention and wellness. One could argue if you spent more, intervened early, got people in healthier shape, we may actually have to spend less on chronic disease. Medicare, for example, will pay very adequately if a diabetic has to go into a hospital and have a limb amputated, often a result of a very serious case of diabetes. But we don't spend many resources trying to prevent that amputation from occurring in the first place, trying to deal and treat the conditions which could actually present a better outcome. So a lot of this underlying legislation is really aimed at beginning to use the payment system, and the Medicare system is the largest payment system in the world for healthcare. We spend over $1 billion a day on health benefits and services, to use that system to begin to not only encourage quality outcomes, but encourage the kinds of medical treatment that we know yield better results, bundled care and accountable care homes and medical home models, the kinds of care that exists in some systems in some areas but is not universally available, which is, again, a huge step forward. I'm a former governor, and I know that there has been a lot of controversy during the course of this debate about whether or not this is a huge federal takeover of something, or whether states are going to have any ability to navigate in this bill. And I would suggest this is one of the most state-friendly pieces of legislation that I have seen during my public service. It starts with the assumption that states really are the leaders. So the insurance regulation stays at the state level. If states refuse to or don't have the interest in regulating, the federal government will provide the backstop. It assumes that states will set up exchanges, either single states or grouped together in regions, that is the best place to start. Again, if states don't want to take on that responsibility, are not interested in providing that kind of market for their citizens, we provide the backstop. So you don't get penalized as an American because of the state you live in if there isn't an appetite to engage in this debate. But we start at the state level. We start with the assumption that as Medicaid is expanded to childless adults, that where in many states they have not covered this population, it's 100% federally funded for the first 3 years, and then gradually the state picks up a share. But the top share at the end of 10 years is 10%, so it's a 90-10 federal match. I don't know of any program that exists right now with a 90-10 federal match. I can guarantee you that none of the health programs have that kind of balance. And at the same time, we're putting enormous resources into workforce, into health IT, into community health centers, changing the footprint, into preventive care, areas where I would suggest a lot of benefits will come to state and local governments. A lot of benefits will come to the citizens throughout the country who then don't have to spend those resources out of state and city budgets at a very difficult budget time. This will be a federal investment in these changes. You know, one of the issues I think that a lot of people forget, because the focus has been on this year-long plus debate on the Affordable Care Act, is that there were several significant pieces of legislation that really laid the platform for this to occur, that began at the very beginning of this administration. So the expanded Children's Insurance Plan, which was the second piece of legislation that President Obama signed, actually expanded coverage to an additional 7 million American children and put in place a more generous federal reimbursement for children's health insurance. And even in the very difficult budget times that we saw last year, 2.5 million additional children were signed up for health insurance. That's very, very good news. The bad news is that we think there's still about 5 million kids who are eligible but not yet enrolled. So we are engaging in very aggressive outreach efforts. We put it on your radar screen here in New York. We're working with community partnerships and provider groups and faith-based groups to make sure that people, particularly in hard-to-reach populations, in vulnerable populations, understand that they can enroll right now, that those benefits are eligible to them. In the Recovery Act, again, one of the first pieces of legislation signed in 2009 by President Obama, there is an historic investment in health technology to convert the system that we have from paper files to electronic medical records, and along with it, to drive meaningful use. So we have an opportunity to really have a quality outcome for hospitals and docs and have a way to measure that. We know it will reduce paperwork. We know it will increase patient safety. Every system that has electronic records in place actually has wonderful results to show for it, but we still have a challenge in this country, so there's a major investment in that shift. There's a major investment in workforce as a part of this bill, doubling the size of the National Service Corps, which allows us to pay scholarships for not only doctors, but nurses, nurse practitioners, mental health technicians, knowing that we need more providers in the pipeline, more emphasis on recruiting minority providers and culturally competent providers, knowing that in many communities it's wonderful to have a doctor, but if the doctor or nurse does not have the language skills and cultural competency to deal with the population, they don't get very far. So we want a renewed effort in that area. Doubling the footprint of community health centers was part of the Recovery Act. Investing $1 billion in comparative effectiveness research. So we really get an opportunity using the best possible research to look at what protocols, what procedures work the best, where are the cost-effective strategies, what are the choices that make the most sense moving forward as we choose health care for the future. And all of that, again, was part of the Recovery Act investment. So the health reform bill that followed really is built on that platform of a really transformational health system. The additional investment made as part of the Recovery Act is the first ever national investment in prevention and wellness.